everyone. I'm excited to introduce this episode for our Medicine 3.0 podcast. My name is Dr. Catherine Isaac. I'm one of the co-hosts and the medical director here at Bionic Health. I had the pleasure of speaking with Dr. Jocelyn Wittstein, who is an orthopedic surgeon and a sports medicine specialist at Duke Health. I first met Dr. Wittstein at an event that she organized and hosted to show the M Factor, which is a movie that is based on educating people about the health impacts of menopause. So I was very excited to reach out to her and ask if she would speak on our podcast about her expertise in the musculoskeletal syndrome of menopause. So during this episode, we touch upon all musculoskeletal health issues concerning women going through the menopausal transition. And we talk about important things like frozen shoulder, we talk about osteoporosis, talk about ways to help treat these conditions and also to minimize muscle and bone loss during this transitional time. So I think it's a very informative episode. And we also share that Dr. Wittstein has a book that she recently released, The Complete Bone and Joint Health Plan. And I think that will bring a lot of value for folks who check it out. So I'm excited for you to check out this episode, and I hope you get a lot out of it. Hi, everyone. Welcome to another episode of Medicine 3.0. I'm Catherine Isaac. I'm going to be your host today. I'm medical director at Bionic Health. And today I'm super excited to bring to you Dr. Jocelyn Wittstein. She is an orthopedic surgeon and sports medicine specialist at Duke Health. Today we're going to be talking about an important topic that I'm excited to share with you, musculoskeletal syndrome of menopause. Welcome, Dr. Wittstein. Thank you so much for showing up here and educating our guests.
Thank you for having me.
So this is a really important topic and actually something that I was completely unaware of until I started to do a deep dive into menopause and the impacts of menopause upon women. And surprisingly, just to give my little own personal tidbit here, I was actually having symptoms of musculoskeletal syndrome of menopause and did not realize that was what was going on until I started learning about it. So can you tell the audience a bit about what that is?
Sure. So as women go into perimenopause and menopause, and as estrogen levels decline or drop off, we start to see the effects on the musculoskeletal system from that withdrawal. And so there are a few general categories where this is felt or maybe not felt, but is silently happening. So one aspect is there is an increased level of inflammation. So we see increased numbers of and severity of inflamed and painful joints. One of the examples of that would be frozen shoulder. So increased joint pain with onset of menopause, and that kind of first 10 years, an accelerated rate of arthritis in joints. So that's one aspect, the joint aspect, inflammation, progression of arthritis, that's accelerated more so in women than men. Another category within the parts of the musculoskeletal system that are affected is bone density. So when we think about bone density, this more rapidly declines in women with onset of menopause. The rate becomes 2% of bone loss per year as opposed to the previous 1% of bone loss per year. So there is a silent process going on with bones where we're getting a more accelerated loss of bone density, making women more at risk for osteoporosis and accounting for 3 out of 4 of osteoporotic hip fractures, for instance. The next category we can speak to is maintenance of and building of muscle mass. Estrogen does stimulate the repair of and the growth of muscle, and so it's harder to maintain or put on muscle mass with estrogen withdrawal. So you have what we call sarcopenia. You can develop osteopenia or osteoporosis, and then you can, of course, have the inflammation of joints, which manifests as things like early onset or more progressive arthritis, and, of course, frozen shoulder.
Excellent. Thank you for explaining those 3 different categories. That's actually pretty significant that it's affecting so many things. When you talk about arthritis, are there any, and just to clarify, so a lot of people get confused when you hear about arthritis. There's like a category of inflammatory arthritis, which is associated with autoimmune conditions. And then there's the wear and tear arthritis, which happens over the years where you get injury to the cartilage in your joints. And so when you're talking about the changes that happen in menopause, it sounds like we're talking more about the wear and tear arthritis that happens over the years. Is that correct?
Well, I like to say that, menopause arthritis is somewhere in the middle. Of course, osteoarthritis is one extreme end of the spectrum of arthritis. Yes, wear and tear, mechanical overload, just, like your tires get worn down over time and, if you use them enough, right? The other end of the spectrum is like purely inflammatory arthritis, autoimmune conditions, things like rheumatoid arthritis or psoriatic arthritis, which are modified by, a whole class of medications, disease modifying medications that, are generally immunosuppressive, but work to halt that disease. The tricky thing is, as we gain more and more understanding about osteoarthritis, we're learning there is some inflammatory component to it. The same inflammatory cytokines in the knee that we see in rheumatoid arthritis do bad things to our cartilage, stimulate breaking down of the cartilage surface, just at a much lower level, to the point that you're not going to use these autoimmune, suppressing medications, these immunosuppressive medications in someone with osteoarthritis. Then you have things in the middle, like post-traumatic arthritis. That's traumatic but inflammatory, and then you get wear and tear. You've got menopause arthritis, where, yes, women are aging. If your average age of menopause is 52, yes, you're experiencing some of the effects of using your joints over a lifetime on whatever load you've put on them.
Mm-hmm.
But at the same time, this is coupled with this increase in inflammation, increase in these cytokines in your joint that break down cartilage. So it's kind of a combined effect of, the aging, the wear and tear, but this accelerated inflammation that men's joints, don't see, which is probably why women have this increased risk of arthritis around the age of 50 that men don't kind of catch up to until about the age of 80, such that women are like 30% more likely to experience osteoarthritis.
Wow, that's super interesting. I was not aware of that. That's very interesting and also kind of sad and frustrating. I'm like,
Yeah.
oh, great, something to look
Well,
forward
there
to.
are ways to, ameliorate that. Yeah.
And I'm wondering, are we talking about the big joints like knees and ankles, or smaller joints also more effective with the menopause arthritis because of this inflammatory component?
So yeah, it's extremely common for people to complain of, hand and wrist pain. So those are of course smaller joints, but also, knees, hips, shoulders. So because there is a generally, systemic elevation in inflammation with the withdrawal of estrogen, yeah, it can affect all of your joints.
Mm-hmm.
And there are, in the actual tissue that lines joints, which is of course called synovium, there are estrogen receptors, and there are plenty of, animal studies that show the effects of estrogen withdrawal and estrogen treatment to, make joints more inflamed or less inflamed. There's a very interesting study recently on, mice shoulders showing that estrogen suppresses the activation of fibroblasts, the cells that make the tissue stiff and fibrotic that we see with frozen shoulder, for instance.
Mm-hmm.
So there's a lot of basic science, studies to explain these mechanisms. And then at the same time, there are clinical studies, like even the early, reports from the Women's Health Initiative showed that 77% of women in these studies reported joint pain, and that hormone therapy reduced the number of and severity of painful joints, and withdrawal of the hormone therapy resulted in some of a recurrence or rebound of those symptoms. But as you probably know, arthralgia, joint pain, inflammation is not currently an FDA indication for menopausal hormone therapy, whereas things like vasomotor symptoms and actually prevention of osteoporosis are.
Right, right. Wow. That's interesting. So I have more questions about that, but I wanted to take a step back just for our listeners because we had mentioned frozen shoulder a couple of times. So I just want to define what that is. And then also, it might even just be worth just saying, like, what are the basic symptoms that people can experience when they're having arthritis? I mean, joint pain, obviously, one of them, but I'll let you share on that.
Yeah. Frozen shoulder is really a distinct entity from arthritis. It actually can happen and usually does happen in the absence of arthritis. But this is a condition that almost exclusively affects women aged 40 to 60. It can occur in men, but generally in the setting of poorly controlled diabetes, which is in and of itself an inflammatory state. But this is a condition that's usually not caused by a trauma or an injury. Kind of women will just sort of notice that their shoulder is kind of achy, and then all of a sudden one day they wake up and it's really painful to move, and then it stiffens, and then it gets, they start to lose range of motion. And after a while, if you get through this inflammatory phase where it's freezing and painful, at some point it just becomes frozen
Mm.
and it's no longer painful, but it's just really stiff. And there's like a lot of impact on your daily life because you've lost so much range of motion. And then it will thaw out over time, but this process might take a couple of years to happen. And hopefully, most people present while they're still in the inflamed state, not yet completely frozen down. Because if someone comes into our office or my office and they're in this inflammatory state, meaning they're trying to move their arm, they can rotate it, but only so far before pain happens. We call that pain at end range of motion. Like
Mhm.
it's okay in this small arc, but when you push it to the extreme, it's really sharp and painful and they can't tolerate it. If someone presents at that phase, you can reverse this condition by putting a steroid injection into the glenohumeral joint, which is the ball and socket joint. And you can stop that train. They'll get their motion back. You'll get rid of the inflammation. If they're already frozen, it doesn't work as well, and we're probably going to have to go through that thawing phase, or we can offer them a surgery to release the adhesions and things like that. But it's pretty much a thing that happens to menopausal and perimenopausal women, and very much known within certain cultures, like Chinese and Japanese cultures have their own terminology for a frozen shoulder that more or less translates to the term 50-year shoulder.
Oh,
It's just
wow.
it's just so common. Yeah.
Mm. That's super interesting. And I really was not aware of the fact that this was something that predominantly affected women. I'm
Hmm.
actually surprised to hear that. I don't
Yeah.
remember learning that. Yeah.
If I see a man that has frozen shoulder, I
Hmm.
often will screen them for a random glucose, or just because it's so unusual to see in a male patient that we have to. If they haven't been screened for diabetes, I screen them. The other group of men that will get a frozen shoulder will be men that have a little bit of arthritis. So they do have a little wear and tear in their joint,
Hmm.
but they're way more inflamed and stiff than they should be for just a small amount of arthritis. So that's like kind of a mixed picture of a little bit of arthritis with a frozen shoulder,
Yeah.
which is different than what women experience.
Right. Interesting.
Hmm.
And so it sounds like, other than the fact that it's the woman is in the perimenopausal or menopausal period, there's no other inciting factor that's going to
Correct.
put her at risk for this.
Yeah. And, it's called an idiopathic condition. I hate the word idiopathic because it just means it's a fancy word for like we don't know why people have it.
Right.
And I truly think the reason why it's been called idiopathic for decades and decades and decades is just that it really primarily afflicts women, and 94% of orthopedic surgeons are men. And I adore my male colleagues. They're all great friends of mine, and they're not even the people that labeled this as idiopathic. But when this was labeled as idiopathic, there were literally, zero or maybe one, you know, female orthopedic surgeon. And so these are not even people who might experience adhesive capsulitis
Right.
or estrogen withdrawal. And so I think it's interesting as more and more orthopedic surgeons become, the sex difference in the field shifts. I think there'll be more women that experience things that women are more prone to experience. I think it just changes the perspective on the condition sometimes.
Hmm. Yeah. Yeah. That's interesting. And yes, that makes sense. Because now you might say it's not idiopathic, but it's an estrogen deficient state, or it's an inflammatory.
Yeah, it's an inflammatory state that most commonly affects women whose hormone levels are shifting. Yeah.
Right.
Mm.
I think, people are going to be listening to this and they're going to be thinking, well, oh, okay, I'm inflamed. How can I know if I'm inflamed? You hear a lot out there about inflammatory states and people
Mm.
worried about inflammatory foods. I imagine, I'm making the assumption beforehand that there's not any tests that you can do to be checking for this, like in your labs. Like, would an ESR or CRP, these are two inflammatory markers, have any value in this setting?
Yeah, I mean, they may be slightly elevated, but not to the level where it would like alarm you to refer to rheumatology for a
Hmm.
truly inflammatory state of, like rheumatoid arthritis level of inflammatory arthropathy.
Right.
These are smaller levels of inflammation.
Mhm.
And some of the studies I'm referring to are based on, literally looking at the cellular level at these joint linings called synovium. So these changes are happening, but they're maybe not as grossly apparent in, screening blood work that one would do. And of course, we also know there's not too much benefit in the state of perimenopause to necessarily measuring things like hormone levels because they're just fluctuating so much, and it's really more about your symptom presentation. And interestingly, it's not like these things occur in isolation. Someone who's experiencing hormonal changes that is predisposing them to frozen shoulder is probably also having some other things like maybe night sweats or hot flashes. Their lipid profile is probably worsening some. Their LDL is probably creeping up because we
Mhm.
see that in the same setting, and their hemoglobin A1C may be creeping up.
Mhm.
So there are these, it's really a metabolic change that's not just isolated to the inflammation affecting the lining of the joints.
Yeah. I think as I'm listening to this, I'm also feeling a bit of like, I don't know what the word is, just feeling like reaffirmed, I guess, in the sense that because when I started to have symptoms,
Validated. Yeah.
validated, thank you, that's the word I'm looking for. I feel validated because I started to have pain in my big toe joint, which is your first metatarsal joint in my foot, and I started to notice some pain at the base of my thumb and my CMC joint. And these are classic osteoarthritis, or so I was imagining, and I was thinking like, oh my god,
You could have both
I
things
could
going
have
on,
both, but I was like, I'm in my early 40s and I'm
and it may
having.
be more symptomatic for you because things are more inflamed as well. So
Mhm. So it's just it's a little validating to say, okay, it's not just aging that was happening, that there may be this pro-inflammatory state that's also happening that's
yeah.
causing the pain to
And
escalate.
and x-rays are always helpful because like I will see things that are very misleading, and I don't want people to think that you can't have just plain old osteoarthritis because you're in menopause.
Hmm. Hmm.
Like I've seen some horrible looking hip x-rays that's just like bone on bone with osteophytes or bone spurs, and someone stating like this is menopause arthritis, and that's not that's someone who probably had a slightly misshaped hip. Maybe they had some hip dysplasia or
Right.
something, or really bad hip impingement and predisposed them to, for mechanical reasons, to have bad hips early on in life. And that's truly more of an osteoarthritis. When we really think of menopause arthritis, think of someone who's going to the doctor like, oh, my joints are hurting, and they're like, well, you've been worked up for rheumatoid, you don't have an inflammatory arthropathy, we've checked you for other things. Your x-rays look pretty good. There's like not that much joint space narrowing, but they've hit 50. So they don't have bone spurs. They're kind of being, maybe they have an MRI where their cartilage looks generally a little bit thin, but there's no internal derangement. But they're like, my joints hurt. Like what is going on? And that's that inflammatory state where there's not like necessarily yet discrete structural changes, for instance. And these women find themselves somewhere in between, like maybe someone might be thinking maybe you have fibromyalgia, or
Ah,
they're getting these
interesting.
workups for things that are, it may just be some increased inflammation and
Right.
joint pain.
So that's interesting. So just to clarify, um, when someone is having like more of this menopausal arthritis, multiple joints are affected.
Can
Not
be.
just okay.
Mm.
So it seems more of like a diffuse or widespread joint pain.
Yeah. Although if there's something that you're using more heavily, like I would say knees and shoulders are pretty predominant in terms of, and hands seem to be like kind of much more predominant things that people complain about.
Hmm.
And
Hmm.
this being said, we're actually studying this in more granular detail now, or I am in combination with many of our Duke Women's Health specialists, because a lot of the early work on this that came out of the Women's Health Initiative was the joint pain component was kind of vague. It was, do you have joint pain, or how many joints, and
Right.
so like a painful joint count, and do you have joint pain or not. And it wasn't, we don't necessarily have all the granular detail of, like in the work we're doing now, we're literally asking about every joint via pain scores of every joint,
Right.
following women every 3 months, accounting for when or if they start hormone therapy and looking at the impact of that, specifically asking about frozen shoulder. So it's much more granular and detailed. And, I really think we need more information about the increased joint pain that we see in menopause, because we have a lot of more granular data on osteoporosis and fracture risk. Like, we know menopausal hormone therapy reduces hip fracture risk by about a third. We have, and it's an FDA approved use of menopausal hormone therapy as prevention of osteoporosis. But I think we need more granular detail on the association of menopause, increased joint pain, how it relates to the known increased risk of arthritis in women, and is there a way to impact that increased risk and, bring down the number of women that need something like a knee replacement, which is, more common in women than men.
Interesting. Thank you.
Mhm.
And so, question. So we know that estrogen is, one of the hormones that's involved. What information do we have about progesterone and even testosterone and the impact on, joint integrity?
Yeah, so there was an interesting study that just came out looking at testosterone levels, and I'm sure you know this, but women have testosterone and men have estrogen. That's just in reverse ratios. Women have about 10% of the level of testosterone that men have. And in this recent study, it was found that both men and women, if their testosterone levels are low, there was increased risk for arthritis. So there does seem to be some connection between testosterone levels both in men and women in terms of risk of arthritis. I think there's a lot less information about progesterone and joint inflammation and arthritis. And again, I'm an orthopedic surgeon that works very closely with women's health providers, but I don't prescribe these medications. In general, women cannot utilize estrogen therapy without progesterone therapy if they have a uterus, because you don't want to increase risk of uterine cancer. But aside from that, if a woman doesn't necessarily need progesterone to protect their uterus, there are other reasons why it may be prescribed, like sleep and anxiety and things like that, for sure.
Mm-hmm.
Um, but I'm progesterone has not really been highlighted in terms of the association with arthritis in the way that estrogen, and now actually it's being explored more as testosterone.
Great. Thank you for that. Okay, great. So we talked a bit about frozen shoulder. Here's a follow-up question to that.
Mm-hmm.
So let's talk a little bit about treatment for women when they come in. What you had started to say, depending on what phase they are in the progression of the disease, that will certainly impact their treatment. But can you share a little bit more about that? Just treatment in general?
Yes. I'm always happy when someone comes in within 3 months of onset of the pain, because there's data that tells us if we treat this earlier, people do better.
Mm-hmm.
And, I have a lot of patients that are really resistant to the idea of a steroid injection, because they just think of steroid injections as being bad things that weaken tissue. Like, I don't want to get into the habit of getting steroid injections, things like that. And I always have to really walk that back with people and try to relieve some of their anxiety around steroid injections, because a steroid injection into the joint is magical for the early phases of frozen shoulder. It will take away the pain, range of motion will come back pretty quickly. I usually do that for people, bring them back about 6 weeks later, and 90% of people literally will ask me if they can give me a hug. They're like, this is
And there
amazing. I was so miserable. It's completely gone. I'm so much better. It makes people happier than any surgery I do. And because it works really well, because you're breaking that inflammatory cycle and you're getting them back their motion.
are.
Now, if someone is really painful with movement of their shoulder, like end range, like if I try to rotate someone's arm and every time we get to the end range, they're like, ow, ow, ow.
Yeah.
It really doesn't work well to send them to physical therapy in that phase, because what happens is physical therapy makes it worse. Not that the therapist is doing anything wrong. It's actually very common for a physical therapist to identify a case of frozen shoulder, because they're saying to the patient, this is hurting you, we're making you worse. And the patient's noticing it, they're getting worse. The therapist almost always will send the patient to us, and they will tell the patient, you need an injection in your shoulder.
Right.
So that's the best time, is if you're kind of painful but not yet totally stiff, is to catch it and reverse it. And many of those people end up not even needing physical therapy. About half of them probably need a second injection, because it'll kind of wear off, and we need to keep the inflammation down so you can keep moving.
Yeah.
Now, if you come in to see us and you're already very stiff, it's not painful, but it's just frozen. Like now, I try to move your arm and it like literally goes this far,
Oh,
like no rotation, and
mhm.
we can't lift it up because it's just socked in, super frozen. For those people, the injections are less effective. We can try physical therapy because it doesn't hurt to move the shoulder; it's just stiff.
Right.
Truth be told, for the most part, it's time that's going to make it thaw out. The therapist will tell you they don't feel like they're necessarily making a huge impact sometimes because it's a time dependent, it's like a self-limited condition. It'll loosen and thaw and eventually get more motion, but there's this subset of patients where they are so frozen, so restricted that they can't do their activities of daily living. And in that group of people, if they can't wait it out or the motion they have is just too limited, we can do something called a manipulation under anesthesia, where we take you to the operating room, sedate you. Personally, I don't like to just manipulate the shoulder. I like to put a little camera in the back called an arthroscope, and through a portal or two, little poke holes, release the adhesions and the thickened tissue and the scar tissue. I always tell my patients it's like a perforated paper towel, and then it can just tear along the dotted line, so we can do a more gentle manipulation as
Mm.
opposed to just cranking on it. There are some people who have a frozen shoulder also have osteoporosis, so their bones are weak,
Yeah.
and the same group. And there's a little risk to just manipulating the shoulder sometimes. You could break the humerus, and that happens very rarely. But we'd like you to not get into that situation. We'd like you to
Right.
not need the surgery. And I will say most people don't need a surgery. Most people, we can treat them with the injection. Most people freeze in a window of motion that's tolerable to them, and they kind of are okay with knowing it's not going to be like this forever. And then there's that small group of patients who really need something done surgically to kind of help them skip ahead a little bit.
Hmm. So here's a question I'm not sure you know the answer to, but if you're in that sort of population of patients who um, they're frozen, not severe enough to necessarily need a surgery, or maybe I guess they eventually would, but does everybody resolve with time except for that, subset of people?
Yes, I mean, it can take a long time, and there is typically a little bit of loss of motion that's residual, but people
Mhm.
get back to some people have no loss of motion. People get back to being very functional. Um, it can be a little bit more prolonged in people who have diabetes. They have a longer thawing process, I would say. And if
Mhm.
their diabetes is poorly controlled, it can just really linger. So for the toughest group is really the menopausal women who also have diabetes. And of course,
Thank-
they're just in a really tough spot because sometimes the diabetes is getting worse as they're going through menopause as well. And so there's a lot going on, but you know, controlling the diabetes can help.
Okay, great. Thank you for sharing that.
Mhm.
Um, so that's frozen shoulder. Here's a question I have, and this might be something that you're interested in investigating or that people are investigating. When somebody presents with these symptoms and they're perimenopausal, menopausal within the 10-year window of onset of menopause,
Mhm.
if they are a candidate for menopause hormone therapy, is that something that you ever recommend? And would that reverse their symptoms?
Yeah, so that is something that we're interested in working on studying. It's part of our registry when we enroll people in it. We are noting if or when they develop frozen shoulder and how they respond to hormone therapy. It's very difficult to design that study because you'd be utilizing a medication for non-FDA approved reason to use it. So we're not like randomizing people with frozen shoulder to getting hormone therapy or not. But like I said, these women all have other associated symptoms of menopause typically. So I do refer my frozen shoulder patients to women's health with the intention of them having, a shared decision making discussion with a member of our women's health team, and they can decide whether or not they want to try adding hormone therapy. If you look at like the basic science behind it that we've discussed, it makes sense that it should help. And I have some patients who really had, just not maybe the typical response that we see to the usual treatment options. They're just struggling. It's really dragging out. And, anecdotally, they've had good benefit from initiating hormone therapy. We did a study looking at our network of patients that are contained within the Duke network, basically within our, HMO system. And we had, many thousands of patients that we looked at, and we identified people that had shoulder pain and frozen shoulder, and people were using hormone therapy and not. And we did find that um, you had twice the risk of developing a frozen shoulder if you were not using hormone therapy, but didn't quite attain statistical significance. And the reason why this is so hard to study is that only 5% of women use menopausal hormone therapy on average, if you look at populations. So you've got a really big number of people not using hormone therapy and a small group using hormone therapy. And in our study, even though we found just like a super small number of people, like literally just a few people that developed a frozen shoulder, it's hard to statistically power this because of the way statistics work. We need more numbers to firmly draw that conclusion. And that was part of the impetus for beginning our registry that we're running at this point.
Got it. Thank you for sharing that.
Mm-hmm.
Okay, let's talk a little bit about. You had started to mention some of the other things that happen for women around the menopausal transition, talking about muscle loss. Can we talk a little bit more about that?
Sure, yeah.
Okay, wonderful. So, so this is an interesting time. Women are having joint pain, they're having physiological
Yeah.
changes, they're starting to gain weight. Tell us a little bit about what might be contributing to the muscle loss.
Yeah, so I mean, there are estrogen receptors all over the body, including on, the cells within our muscle, the cells that like have to be activated for muscle to grow and repair.
Okay, for
So part of the natural history of aging is, on average, we're maybe losing 1% of our muscle mass per year, 1% of our bone density per year,
mm,
um, beyond something like the age of 30. But again, both of those losses accelerate in menopausal women in the absence of hormone therapy. So there has to be frustratingly, more effort put into building and maintain muscle mass to not lose it. You would love to gain muscle mass because we know programs that focus on gaining muscle mass that include resistance training or strength training actually help preserve bone density. So, one of the main reasons we want women in this phase to do more strength training and gain muscle mass or maintain it is because that stimulates bone density. Also, gaining muscle mass helps with things like, insulin sensitivity, which of course reduces inflammation, which makes your joints feel better. So there's, it's so all interconnected and intertwined. You really can't separate.
hmm Yeah, so that's great. Thank you. So that's an important connection, I think, to highlight that yes, it's important. Muscle is important, but it has a number of functions. And as you build muscle, you're benefiting your bone as well, which is, crucial because, as you said, we have that accelerated bone loss during that period of time. One thing I don't know the answer to, do you know how long that accelerated bone loss continues until it goes back to that baseline of 1% per year?
Well, once you're menopausal and, you know, in basically absence of the estrogen levels, I mean, so that's your new state. I mean, it's pretty
Okay.
much, yeah,
You
that's
just
why
maintain that higher
you
level of bone
you
loss.
just keep losing bone loss, which is kind of, I don't mean to be too depressing about it, but yeah, that's why women have to be so purposeful, or we would like women to be intentional about maintaining bone density, because even to just maintain it means you're actually having to like almost gain some, right? Like if the natural state is to lose, you're having to, if you are not losing, you're actually doing really well, right?
Right.
Because you're not, you're staving that off.
Yeah.
And I don't ever want people to think it's too late to start building bone density or starting activities that will help them not lose more bone density. But the really concerning part, of course, is that, our for bone density, it peaks around the age of 30. And so you have your adolescence and your 20s to build up that peak bone mass.
hmm
And then it starts to gradually decline, 1% per year. Then, of course, it becomes more precipitous on average age of 52 with menopause. And a lot of people have spent, their 30s and 40s doing primarily things like cardiovascular exercise, maybe not so much strength training. Some of the cardiovascular exercise may involve some impact, which is good. That can help with bone density. But and cardiovascular exercise is good for other reasons, like your cognition, dementia prevention, your, cardiovascular health. But a lot of people are arriving to menopause or perimenopause not having done a lot to build up their muscle mass or to just start the habitual, strength training. And so people sometimes think, well, if I miss the boat in my 30s and 40s, like I'm just, is there nothing I can do now? And it's very encouraging if you look at the results of studies of menopausal women who are newly engaged in exercise programs that include resistance training, so strength training plus a little impact. They can gain in like some of the studies, they usually range from 6 to 8 months of intervention. You can see a gain of a few percentage points in lumbar spine bone density, and some of the jumping programs, gaining a percentage point in their femoral necks on a bone scan, which is, I don't know that, we don't have data to show that you just keep gaining and gaining and gaining, but like getting into that habit kind of brings you to a new level and will hopefully keep you from losing more. So
Right.
gaining a little bit is a big deal. If you should have been losing 2%, if you gained a few percent, that's a really big deal.
Yeah, absolutely. As you were talking, I started imagining patients that I've seen in the past who they're getting into middle age and they start to feel that pressure of their changes in their body, and then they decide to start working out.
Mm-hmm.
And you would see this like typical collection of musculoskeletal issues arise for people when they start.
Tendonitis and things like that. Yeah.
Yeah. So can you talk a little bit about that and kind of strategies that people can use to try to minimize injury?
Mm-hmm. Yeah, I think if you're someone who's new to strength training, for instance, it would be helpful to work with like a good personal trainer. It's You can't just go start lifting at like 80 or 85% of your maximum lift. You probably wouldn't even know how to determine what is your one
Right.
time
Right.
single rep max, which is literally what's the most you could lift doing a certain maneuver one time. And usually we're talking about things like an overhead press, a deadlift maneuver, and like a squat. So these are things that maybe people haven't even done. So it's best to start with like body weight based, make sure you can do that with good form. And then it's better for people to start with a lower intensity resistance training, meaning like lighter weights, higher repetition at first. Like maybe you start with a few sets of 8, where the eighth one you can still do with good form, but it's kind of hard for you, but you can maintain good form. And then it's good to spend a couple of months like gradually building up, where you start to lift a heavier amount with those maneuvers. And as your heavier amount goes up, the number of repetitions goes down until you ultimately might arrive at like a higher intensity where you're doing, maybe you do your squat and your deadlift and your overhead press. And instead of it being, a few sets of 8 to 10, maybe it's, 4 sets of 5 or something like that. But you're working your way up to that. And then people need to recognize their own individual like health conditions. There are some people who, they may have a rotator cuff tear or a history of a rotator cuff repair, and maybe they shouldn't use overhead press as like one of their like higher weight exercises. So it has to be individualized as well.
Yeah, definitely. Thank you. I think that was really good
Mm-hmm.
guidance. And I do think it's a great time in a person's life to invest in working with a personal trainer for that
Mm-hmm.
exact reason, like understanding proper form and knowing one's limitations to prevent injury.
Yeah. And if
Um,
you've had an injury that you were previously seeing a physical therapist for, a physical therapist is not a personal trainer, but a lot of times patients are wrapping up a course of physical therapy for something like maybe they had a knee arthroscopy because they had a minor meniscus tear or something like that.
mhm.
A lot of times those physical therapists are helping the patient exit physical therapy with a home exercise program. And so they can in some ways make sure you're at least knowledgeable about like, you know, what that individual can tolerate it and how they can do it, or maybe ways they can work around their most recent condition. So they can be a good resource for you, but they're not going to do your workout with you 2 or 3
Right. Right. Can you talk a little bit about bursitis of the hip? Because that's just something that I would commonly see from my middle-aged patients who are interested in getting back into exercise.
Yeah,
And it seemed like even just kind of ramping up walking too quickly seemed to trigger
yeah.
that. Can you explain what that is? And
Yeah. So trochanteric bursitis is just pain literally like right on the side of the hip. And when people start walking, if they increase their distance like suddenly or they increase their speed, and then you get this like friction over, I'll just stand up and show you, like right over the trochanter, right on the side of the hip there, there's like tissue that's rubbing over the most prominent bony aspect of your hip called the trochanter. And yeah, it can become sore and irritated just from almost like friction in that area. But another thing that makes people more likely to get bursitis in that area is if they have weak hip abductor muscles. So the muscle isn't kind of maintaining the position of the hip, and that weakness in that muscle makes people more prone to getting bursitis. And so usually that is a good indication to see a physical therapist. And a lot of the strengthening that a physical therapist can give you to do can help you not get back into that pattern. Occasionally, doing a single steroid injection into that bursa can alleviate symptoms, but what is not a good idea is to just keep getting that bursa injected, because you can end up with some tearing of the muscles, of the gluteal muscles that attach to that area. And we kind of call it the rotator cuff of the hip, your
Mm.
gluteus medius there. It can tear, and it's like how we use our rotator cuff to abduct our shoulder. There are muscles around the hip, like the gluteus medius, that helps us lift our leg away from the side or maintain a single leg stance. And if you just keep injecting it, you may actually be masking a tear of that tendon.
Hmm. How often do people actually end up having tears there? Do you know?
It's hard to know because who knows the true like
Right.
numerator.
Not everybody's getting imaging of that area.
But occasionally, yeah, you'll see someone who's just had their bursa injected like 5 times, and you're seeing them for the first time, and they just want their injection, and it's like, no, you need an MRI. So,
It's not a
yeah.
good plan.
Mhm.
Okay, excellent. Let's see. I think we've covered pretty much all the topics that I was interested in talking about. Definitely covered frozen shoulder management, just general joint arthralgias and arthritis, and anything else that you think it's important for people to be aware of.
Yes. So there are only so many things you can control necessarily about your, musculoskeletal health. But I think the parts of people's life or their lifestyle that are most under control, that can probably most impact their bone and joint health, is their, exercise choices and their diet. So we talked about exercise choices. You do need, again, I don't like to think about things in too much of a silo. Like, even though I'm an orthopedic surgeon, I don't want to give people advice that is strictly for their like bones and joints. So we know that, one of the few things that's been shown to protect against dementia is 150 minutes a week of cardiovascular exercise. So I don't want you to tell you to not do cardiovascular exercise. And we know that's also helpful for your heart health. But, you need to include some strength training. So resistance training a few days a week is good for bone density. A little bit of jumping, if your joints can tolerate it, even if it's just 30 jumps of some sort a few days a week. A little bit of impact will stimulate bone density. Good to include some balance training, like single leg balance, so that we reduce your risk of falls. So if you do have good bone density, we also, it'd be nice for you to not fall and not test it out.
Right.
And then dietary choices, for your bone health, you obviously want to get enough calcium and vitamin D. It can be quite hard to get enough vitamin D through your diet, so totally okay to supplement vitamin D. And then, don't forget micronutrients that are available, like outside of dairy, for instance, so a lot of micronutrients contribute to our bone health, like things like magnesium and vitamin K. And then from your dietary perspective, you can also try to employ an anti-inflammatory diet that may help some with joint pain.
Hmm. And can you tell us a little bit about like anti-inflammatory foods that you would recommend?
Yeah. So, I try not to be too strict in these definitions, and people get really fixated on like what's an anti-inflammatory diet and what's not. But in general, if you can minimize the inflammatory things and optimize the anti-inflammatory things, that would be good. So, minimizing red meat, minimizing fried foods, saturated fats, minimizing processed foods, definitely processed meats. I like to minimize those. And then including a good amount of dietary fiber, at least 25 grams a day, whole grains. Try to get a variety of fruits and vegetables, so you're getting a larger variety of the many of the anti-inflammatory aspects of fruits and vegetables, like antioxidants, and then there's a whole slew of phytochemicals that are anti-inflammatory as well. Omega-3 fatty acids are anti-inflammatory, and you can get that from fish, and some things like walnuts and chia seeds and things like that. But if you don't eat much fish, you might want to use a supplement for that. And then whole groups of foods that are anti-inflammatory, like things like the whole class of alliums, cruciferous vegetables, things like that. But a lot of things you can do to boost the anti-inflammatory component of things. I think it's easier to add anti-inflammatory components for people than it is to sometimes remove some of the inflammatory aspects that they
Mm,
have in their current diet. So I
right.
think any change you make helps. It doesn't have to be
Yeah.
all or nothing.
Well, it's so wonderful actually. As you were going through that, I was like, okay, so basically just like try to eat better quality whole foods.
Yeah, getting more fiber. So
Yeah.
lean proteins, more fiber, variety of fruits and vegetables.
Hmm.
There's certain, like I said, subsets of foods that are pretty anti-inflammatory, some spices. So there's a lot you can do. And I don't mean to say that diet is going to make you, like an anti-inflammatory diet is going to make you not need a knee replacement. That
Right.
I'm a surgeon and I believe in surgery. But when people are looking for ways they can optimize their bone and joint health, those are the things I think that they can control. Also, body weight, which is not under everyone's control, perhaps based on metabolic syndromes, but maintaining a healthy body weight will certainly help with reducing symptoms of joint pain and the need for joint replacement surgery in the future. That is, I will say, somewhat under our control, but very, very difficult. And so I think people always want to know, like, I mean, all the time I see people in my office and we're doing surgical counseling, like they're scheduled for a rotator cuff repair next week. And I'm giving them all this detail about what their post-op course is going to be
Right.
like and risk and benefits of surgery. And I'll say, do you have any more questions? And on the way out, they ask me, everyone asks me, what should I eat? And are there any supplements I can take? Or what kind of exercise should I do? It just,
Right.
it's really broad questions and that gets your whole lifestyle. But
Yeah.
some of it certainly is helpful. So
Yeah. Excellent. That was very helpful. Any last information on resources for patients of where they could educate themselves more about, maintaining good musculoskeletal health, or information for women who are transitioning through
yeah.
menopause?
Um, Dr. Vonda Wright and myself, we co-authored a paper that is publicly available from the journal called Climacteric, which is called the Musculoskeletal Syndrome of Menopause. So anyone can access that, download it, and read it. It is like at a higher, medical sort of terminology level. Um, and then, but it kind of, I tried to summarize a lot of what is in that, and throughout some of our other work. But there is a site offered by the American Academy of Orthopedic Surgery called OrthoInfo, which, while not specific necessarily to symptoms associated with menopause, does offer a lot of really good patient-facing information about, like, how should I treat, what are ways to treat tennis elbow or frozen shoulder or things like that. And it's a really nice resource for people, and it's very much at like the patient level. And then and you can feel free to remove this, but because I've always wanted to just sort of package up all of this information for people. These are the questions I get all the time. What should I eat? What exercise should I do? What supplements should I take? I did ultimately write a book about this because I just
Mhm.
wanted people to have this. I wanted it all to be in one place, and I co-authored it with my lifelong friend, Sydney Nitskorsky, who is a registered dietitian. So I'm
Wonderful.
an orthopedic surgeon. She's a registered dietitian. I also studied nutritional science at Cornell as an undergrad.
Oh, you did.
Yeah, so
Wow, I
I'm
didn't know
more
that.
interested in nutrition than a lot of orthopedic surgeons might be. But yeah, this is called the Complete Bone and Joint Health Plan,
Excellent.
and it's
I need a copy.
yeah, you can get it on Amazon or Barnes and Nobles or wherever you buy
Wonderful.
books, and it's basically answers these questions for people. Like, what is arthritis and the different types? What is osteoporosis? What's an anti-inflammatory diet? What are the components of a bone health diet? What things do you need for your bone and joint health? And then there are recipes that blend all those things together, and
That's wonderful.
exercises, and then the frequently asked questions that are all the things that my patients ask me all the time that I mean, literally, I didn't have to think about this at all. Like, what should I put in this second? Because they're so ubiquitous, the questions that people ask. And so
Mhm.
if you need to go see an orthopedic surgeon because you have an orthopedic condition, I think it's helpful for people to have information, going into that visit or with any doctor, maybe their primary care or whoever, to just be so that they can be more educated and then they can get more out of that visit because they're like almost prepared for the visit.
Yes, excellent. That's wonderful. I'm so glad that in addition to being a mom and a full-time physician, surgeon, that you actually took the time to take all of that knowledge and put it into an important package for people in your book. So that's wonderful. And thank you for doing that.
Yeah, I hope it's helpful to people. I don't tell my I mean, I get really behind in clinic because I talk about all this stuff when we're supposed
I
to be
can
talking
relate.
about your surgery day. But I don't just tell people go read this book, but I do think it helps people or will help people, and maybe it'll help other doctors if they don't know all that information. I just want people to be able to find it. So
Yeah, absolutely. I mean, I think just coming from the perspective of a physician, like despite all of, our best efforts, there's so much new information that is
Mhm.
coming out at all times. It can be hard to keep up with every single, area of medicine,
Oh,
especially when you're in
absolutely. I mean, I finished,
there.
the process of a book coming out is a long time, and I finished it a long time ago. And there are a couple of things like if I could go back and add it, I would now. I might have to do a new edition or something.
And or maybe book two.
Yeah, something like that. So
Yeah, wonderful. Well, again, thank you so much for putting that information together for patients, and I'm glad that we'll have the opportunity to check that out. And I just love that you came on and spoke on the Medicine 3.0 podcast. It's been such a pleasure, so informative, and I really appreciate you volunteering your time to be here today.
yeah, thank you for inviting me.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.